very, very warm welcome, everybody, this Friday. And this is our 16th Street Drugs webinar. And we started live before the pandemic, but this is our 16th since the pandemic began. And actually talking about the COVID-19 pandemic is very appropriate because today's webinar is all about what happened when the pandemic struck, to the response of different countries to the treatment and support for people who use drugs, and kind of have we learned anything from that, and are there good practices that appeared that we have carried on. And we're also, so that's the sort of first part of the discussion, and we're also going to learn about what happens in war to people who use drugs, and that is our second speaker, Jennifer's expertise. And she's done a lot of work in the Ukraine. So what's happened in the war in Ukraine to people who use drugs, people who inject drugs, and people with other comorbidities. So this is fantastic research that our speakers today have done. I've had a preview of the slides, and I'd have to tell you folks, you're in for an absolute treat. So I'm going to introduce you to the first speaker, Caroline Parker, who's speaking from the University of Manchester. Hey, and she is a medical anthropologist. Both our speakers today are medical anthropologists, so we're in really good hands. She is a presidential postdoctoral fellow of medical anthropology at Manchester University. So that's pretty cool, people. Most people don't get a presidential fellowship, I have to say. So her work combines cultural and medical anthropology and carceral studies with a geographical focus on the Caribbean and the United States. She has published her work in the New England Journal of Medicine. I have to say, most people don't achieve that in their whole career. Caroline, it's fabulous. She looks at how drug policies and the practices of confinement during late capitalism in the Caribbean are changing the nature and meaning of social belonging for people who have formerly been in prison. So I'm going to stop talking now and hand you over to Caroline. Thank you, Caroline.
Thank you, Jo. Thank you for that very generous introduction. Is there a way for my presentation to come up?
Well, we thought it's probably easiest for you to share your slides.
To do it?
Yeah,
that's absolutely
and we
fine.
have them if there's any.
Sure. Okay.
That's perfect.
Yeah, you can see my slides.
Yeah.
Perfect. Okay. 1 second.
And I'll just say, everybody, don't forget to put your questions in the Q&A. And your general comments in the chat about how brilliant this is and how much you're enjoying it and all the rest of it. But questions in the Q&A is much better, because then if we don't get a time to answer them live, we can answer them online for you.
Great.
Thank you.
So hopefully everyone can hear me.
Yeah.
And yeah, thanks again for giving me the opportunity to share this piece of work, which is a collaborative piece of work that was produced by the SU COVID Data Collaborative that I'll be saying a lot more about. And the piece that I'll be talking about today is about to come out any day now in Global Public Health. It should be out soon, and I can definitely share this along with our mailing list as soon as it is published online. In terms of what is the SU COVID Collaborative, we're an international network of social scientists, including anthropologists, public health scientists, and community health practitioners. And our network convened somewhat haphazardly, I would say, around March 2020, as many of us around the world entered into our first wave of COVID lockdowns. Our initial members were identified with technical assistance from the International Society for Addiction Medicine, the Open Society Foundation, and the US National Academy of Medicine's Opioid Collaborative. But today, the last time I checked, we had over 60 members from countries spanning 13 different field sites. And this paper is kind of one of our earliest papers in terms of us writing it. which was about what we've learned so far through comparing different countries' national responses, not necessarily drug policies, but policies that affect the health and well-being of drug users internationally, and focusing specifically on what for most countries was the first period of lockdown. So it varies a bit, but talking broadly about March to August 2020. So the COVID-19 pandemic created an unprecedented natural experiment in drug policy, treatment, and harm reduction by exposing strikingly wide variation in public health infrastructures and in social safety nets around the world. The questions we were interested in as a collaborative were twofold. One is how do pre-existing policy conditions, such as differences in investments in social safety and public health infrastructure, how do they shape the capacity of governments to mount an effective pandemic response? And which institutional domains, beyond the direct provision of healthcare, I guess, are most critical for policymakers and practitioners working to assure the health and well-being of people who use drugs? And just as a kind of spoiler alert, I'll just tell you what we found, in case you have to go. So we found that countries with stronger social welfare systems prior to COVID introduced more centralized and durable interventions targeting the structural drivers of health, and that countries with more fragmented or weaker social service infrastructure tended to lean into very temporary initiatives for people who use drugs. And so I'll flesh this out and give it a bit more life today, and I'll end with some policy recommendations. But just to wind it back a bit, I guess prior to COVID, if we think about global epidemiology, in 2019, there were about 35 million people worldwide were living with one or more substance use disorder. And of that, about 11.3 million were using drugs by injection. In 2016, global estimates of substance use related deaths ranged from about 140 to 450,000. And during this time, we also have massive international variation in how governments were responding to people who use drugs, right? So I'm not going to spend too much on that. But, I guess this map on the board gives a sense of geographical distribution of safe injection or safe consumption sites. There's massive variation in access to harm reduction, access to safe syringe programs, access to MOUD. And then I guess beyond these kind of direct drug service provision, there's huge international variation in the extent to which governments have embraced the criminalization of drug use and kind of carceral punitive responses and public health investment. So that's all part of the structural context, I guess, that is quite relevant to thinking about how people who use drugs are going to fare during the COVID pandemic. So against this kind of backdrop, what we're thinking about is how do these pre-existing conditions shape the capacity of governments to respond to the problem? And what are these kind of critical domains of policy that are important to think about when we're thinking about people who use drugs? So as I mentioned earlier, our collaborative members, many of them were community health practitioners and activists working on the front line throughout this time. We all began meeting on a kind of virtual basis, on a bi-weekly basis. And through these meetings, we began gathering early field reports or field data from across our collaborative. So this included ethnographic field notes. It included interviews with people who use drugs and with staff who were delivering healthcare in healthcare facilities and harm reduction organizations and community outreach programs. So I was one person in a core team of analysts who compiled and did an initial coding of the fieldwork. And I was also one of the analysts who designed a follow-up survey across our collaborative to kind of probe for more information on things that were missing, to balance out what we were finding, and to clarify things that were less clear. And from this process, about 4 cross-cutting themes emerged that I'll kind of touch upon each. One is that we have very, very broad definitions or varying definitions of what constitutes care across sites. Another was that grassroots and peer-led organizations were playing really critical work during this time. We saw really surprising changes to law enforcement and imprisonment practices, which I'll be talking about more. And we also saw kind of very variable effects on drug markets and patterns of drug use, which I probably won't have time to go into today, but we can talk about later. In terms of how our kind of basic question of what is happening to care and the responses we got, what was striking when we collated the field reports was that the policies and institutional responses that were impacting people who use drugs around the world went way beyond specialized services for drug users. So things like MOUD and syringe exchange and naloxone and safe consumption sites, they were part of this institutional landscape that mattered. But other policy domains, including the provision of stable housing, early release from prison, and changes to policing practices, these were other really important domains too. And so I guess throughout the rest of our analysis, we were thinking about care in this kind of broader definition. There were some major changes that happened during the initial COVID lockdowns. In terms of MOUD, some countries did a lot better than others. Countries that were reliant on international aid or international provision of MOUD were hit quite hard. So Uganda and Vietnam both had to either discontinue or radically reduce MOUD when overseas funders kind of ceased doing face-to-face services. But there was big international variation here. So Iran actually removed a lot of the bureaucratic barriers that had existed to take home doses of methadone. France managed to extend its refill period for both methadone and buprenorphine. In Kiev, Ukraine, I'm sure Jan can provide an update, but for a while, all methadone patients were transitioned to a 10-day take-home supply. And so, yeah, we saw some countries kind of halting and some countries really pushing through legislation to remove barriers. In nearly all countries, we saw a growth in the use of telehealth and virtual support groups like virtual Alcoholics Anonymous, virtual Narcotics Anonymous. In some places where not everybody have phones, such as in Uganda, that was used less. And telehealth, we kind of found that while fulfilling some important role undeniably, we also saw some adverse consequences with field reports in the Netherlands and the US specifically indicating increased domestic violence associated with telehealth. In terms of criminal justice, we saw massive variation. And also when it comes to housing, actually, I'll do housing first. So on the very proactive side, French authorities in Paris managed to pay for several hundreds of emergency housing units for people who use drugs, and also deployed social workers and psychiatrists to prevent social isolation. Edinburgh and Glasgow did really interesting work rehousing people and virtually eliminated outdoor sleeping in both cities within 72 hours. In the US, the outcomes of kind of housing related efforts were much more fragmented and variable. So many cities lent into using hotels, and most efforts to increase housing were kind of overwhelmingly concentrated in California and the northeast of the country. In Los Angeles, 15,000 hotel rooms were reserved for homeless individuals, but our field data suggests that only half of these were ever filled, and partly because many people did not want to move away from their social networks, and so it was kind of a rushed initiative that didn't have as widespread uptake as they had hoped. Similarly, 3,000 homeless individuals in San Francisco were relocated to hotel accommodations as of May 2020, but these arrangements were temporary. New York City saw a kind of escalation between hotels and residents, whereby the city placed about 700 unstably housed people in quite upscale hotels, leading local residents to complain, and then a series of court cases seeing them allowed and not allowed. And so that flip-flopped around for a few months. So I guess the kind of hotel initiatives in the US were limited by fragmented planning and local homeowner resistance, which I guess are part of the conditions that mirror social safety nets prior to COVID. Just a word on law enforcement and changes there. So we saw some really interesting curtailments in policing and in arrests in many cities across the UK, France, Mexico, Iran, and the US, especially during the first few months. These temporary reductions in policing activity they seem to be more devised to protect the health of officers, usually, than to protect the health of people who are police. That's not based on doing a systematic research into that question, but what we can infer from how they were implemented and the timelines, because they didn't last very long. But Tijuana, Mexico was a really interesting example there. Tijuana is a place where there is quite a lot of persecution of drug users, where it is not that uncommon for police to do kind of sweeps, like the kind of sweeps of homeless encampments that you see in San Francisco and other cities. But for a while, a lot of these practices stopped for about 4 months. So that was a relief. But we haven't seen a lot of these gains transition into a more permanent change. So that's something to think about. Scotland did some really interesting work. The Scottish Prison Service approved a new initiative of having officers carry naloxone, and that was expanded. They also strengthened a lot of support systems for recently released drug offenders, including their outreach efforts, linking people who have survived overdose to outreach. And they introduced a new legal amendment to allow for community members to administer naloxone. Some more worrying things happening in some American cities. So in Philly, police attempted to enforce social distancing among homeless individuals. I'll quote this, by sounding bullhorns and yelling in the faces of homeless individuals without wearing masks. In Virginia, where there were various safe injection sites that had moved outside to reduce COVID transmission, they had this a side effect of police kind of persecuting people near and around the self-injection site. So really undermining the public health initiative, kind of left hand, right hand, really not talking to each other. In terms of prisons, a lot of governments announced plans to release people from prison, but they were really patchily implemented. So in the UK, only 257 people were released from prison by August 2020. But 4,000 people had been reported eligible by the MOJ. In Mexico, only 59 people were released from prison as of April 2020, but 1,835 had been given ankle bracelets to prepare for release. So 1,835, 60 release, not great numbers. Actually, some surprising differences here. In California, Los Angeles and Sacramento decreased their jail populations by 30%, so massive decrease. And this was achieved through early release, through suspending cash bail, and through suspending pretrial detention for nonviolent crimes. And in Iran, the government released 85,000 prisoners, estimated as early as March 2020, and also suspended all drug arrests. And so, yeah, that was really, really surprising, like lots of variation there. I haven't had much time to touch on the kind of grassroots peer-led organizations, but we found that the burden globally of responding to basic needs of overcoming barriers to care did fall disproportionately onto NGOs and community organizations, and even more so in countries with weaker social safety nets. And these organizations are providing essential services like food and clothes and showers, things not typically given by healthcare services, also making sure that people had access to phones and internet so they could use the things that had gone online under some government systems. So they were very flexible. They did a lot. They had fewer bureaucratic barriers, but the usual kind of problems of a lot of underfunding and in many cases not being recognized as an essential service provider. So I guess, oh yeah, I've already touched on that. But much remains to be learned about the full public health impacts of COVID lockdowns and associated policies on the health of people who use drugs. And I think our reports don't necessarily allow for a generalizable conclusion about which policy was the most effective. But I think they do illuminate concrete examples of good and bad practice from different countries and political contexts that are important to policymakers and to healthcare service providers. So the table on the board summarizes what we think to have been some of these successes. You can have a look at those. And yeah, I guess, stronger social safety nets, stronger public healthcare systems, stronger pre-existing harm reduction infrastructures. In these contexts, we saw interventions more likely to target structural drivers of these problems, things like housing, things like decarceration. Some of the things we saw that were interesting were short-lived, such as the hotel initiatives. They didn't have sustainability. And I guess the degree to which police and criminal justice were involved in responses prior to COVID didn't necessarily predict the level of criminal justice involvement in responses to COVID. So we saw some really, really exciting decarceration things in places we didn't find. I guess the challenge is seeing how to kind of maintain these gains that have been had into more sustainable policy change. And we came up with a range of policy recommendations based on the things that we had found. I think this slide has a longer version. So yeah, ensure unimpeded access to support service, housing services, and law enforcement and sanitation department closures of homeless encampments that displace unhoused people from their social support networks. Yeah, I think maybe it might be better time-wise to not have me read them out, but we can come back to these later. We had a full series of recommendations, but some non-surprises here: decriminalize drug use and possession in line with the UN nation common position on drugs, reducing prison populations. So these are the recommendations we made, and they're actually quite extensive in the article, which I can share around. But I'm going to stop there so that we can come back to all of this and just say thank you to all of the members of the collaborative. And if any of you are here, please say hello. I also have COVID, so I'm sorry about my voice.
Oh, Jennifer, or Caroline. That's such an extraordinary study. What an undertaking. How did you choose, or which countries would take part? Or I guess it's part of a network.
Yeah, so I think that we were quite keen when the kind of first few members came together. I think because of how we already know each other, it was quite US focused, and we were very keen to ensure kind of a more balanced global participation. So the Open Society recommended quite a lot of researchers to us and practitioners. Helena Hansen, who's now at UCLA, worked very tirelessly to try and work with colleagues who she had worked with in other countries and in other states to try and get it away from just the coast and things like that. So the network kind of grew in a way that was exciting, at times unwieldy, and unpredictable, which was nice.
And some really surprising results given the nature of kind of the country.
Yeah, no, absolutely. I think, and I think what we also saw was variation within countries that was interesting. So, differences between England and Scotland were huge, and things happening in the US in different cities were huge, and interesting things happening in Uganda and in Iran that, I say surprising, but I don't work on either of those countries, so I probably shouldn't be that surprised by anything. But it was, a real motley picture. And I think that we just hadn't really anticipated how many different domains were going to be relevant to this, because I think we initially were thinking about things like harm reduction services, and it turned out to be a much broader picture than that.
And do you have any sense of the practices that were kind of most successful? Was there sort of measures of success?
So in this paper, we're not having kind of measures yet, because it was this kind of snapshot. It was a very kind of here is things as they are unfolding. And this will give you some insight into, I guess, timelines of academic publishing, because I think one of the things we were really keen to do in this paper was to push out an emerging snapshot as it was unfolding, using this comparative data to see what was happening. But lo and behold, shepherding a lot of things through processes of blind peer review in what year are we in now, 2022, timelines become a little less prescient snapshot and a little more. Now we probably could have done a follow-up study, but these are the constraints that we're all living in. And I think that probably there are actually quite a lot of structural reasons why knowledge production takes so long these days.
And for some reason, reviewing and publishing has got worse in the pandemic. Horrendous.
Yes. Yeah. And, and I think actually part of the collaborative's work as well has involved putting out quite a few things that are not peer reviewed, just because it's quicker and it's more available information. And I'm sure that Sarah, who convenes our mailing list at the moment, will probably have a lot of that to hand that I can find.
And are there plans for a follow-up study?
Jen?
I'm not the right person to ask. I've been buried under teaching for the last few months.
I think that the things have morphed into various different things. So I know that there was a special issue at AJPH, which had a lot more research heavy pieces. And I think that is now out, and that was looking at overdose. So I think I think we're quite unwieldy, but I don't think there's a follow-up of this specific paper in that sense.
I mean, do you have a sense that some places have carried on these practices? You know, because this was your work was in the first wave of the pandemic when we were all locked in, wasn't it?
Yeah.
So now that we're, you know, you're a good example, people, we're still getting this and we're still in this pandemic, but, you know, things have loosened so much. So is there a sense that the good practices carried on?
Yeah, so I mean, I can only really speak to my own field site, which is Puerto Rico, and I think there've been quite a few intersecting things happening at the same time. And so its prison population is getting smaller and its arrests are lowering, but the extent to which that is COVID or the extent to which that is government cuts and austerity and the extent to which that is overcrowded prisons is kind of unclear and hard to untangle. But it means that rates are going down. And yeah, so in that sense, yeah, some of those decarceration things have continued, but there are complex reasons for that. And I think that that is not necessarily mirrored, for example, in Mexico, where I don't think that has happened. I think it's
so. This is a bit of a random question. Do you think, so Joe Biden has released, hasn't he, or said he would release people in prison for cannabis possession, supply offences. Was that anyway sort of brought about by the success of what they did in the pandemic? Not particularly in the States, though, I guess.
I would say no, honestly, because those are two very, very different public campaigns. I don't think one was being conflated with the other. And there's actually very, very few people incarcerated on federal charges of marijuana possession. And that's specifically what he granted immunity. So it's a step forward, like no one's really complaining, but also there's an awful lot more to be done. It's a very, very first small step. So actually that move is going to release disappointingly few people, though some, which is good.
Yeah, absolutely. That's really good point. I thought your example, Caroline, of what happened in Edinburgh and Glasgow, as obviously living, in the UK, rehousing all the homeless people in 72 hours. It's extraordinary, isn't it? And it just shows what can be done.
Yeah, absolutely. And I think that some of the kind of work being done, particularly with like the Scottish partners, it sounds like just a much more innovative legal system, and any of the constraints seem to be like UK constraints. And in terms of like the things that police already do in overdose-based outreach and things like that, it seems like a very different policy landscape.
Yeah, certainly. Now, Jen, you say there are no public safe consumption spaces in Virginia at all.
No, we have one legally operating safe consumption site that's in New York City. There's certainly plenty more, but and there's some that are operating on the West Coast under the law, but I think in full knowledge of local actors. But yeah, for the most part, all safe consumption facilities that exist in the United States, of which there are many, are extremely protected and underground.
Mm-hmm.
Interesting. Yeah. Now, James Morgan will correct me if I'm wrong, but I don't think we have any in the UK left after the.
No, we never. The only one we had, as far as I know, was Glasgow, and I know at least Peter Crichton has had to move back from that. Whether it's still happening, but yeah, we've never. Central government has never given them the green light. So yeah, it's what we've been asking for forever. And it was only this very much kind of left field, amazing work by Peter Crichton that we've actually had here. And yeah, I'm not sure when that will change.
So I just plugged Drug Science. Have got a working group on safe consumption sites. led by Alex Stevens from the University of Canterbury in Kent. So there's some great work going on in the UK, but we're just hitting a government brick wall. It's heartbreaking. Okay, so just to remind you, the audience, don't waste an opportunity to ask the experts all your questions about this. Just put your questions in the Q&A. Put your hand up even. We've not got many people. I'm sure James Bunn at Drug Science will let you speak. That would be fun. Okay, so we're going to go on then to our next speaker, Jennifer Carroll, who's also a medical anthropologist. She's also a research scientist and a subject matter expert on substance use and public health. So we're in really good hands, people. She's assistant professor of anthropology at North Carolina State University and adjunct assistant professor of medicine at the Warren Alpert School of Medicine at Brown Uni. Busy, very busy life. She also consults for the National Center for Injury Prevention and Control, part of the US Centers for Disease Control and Prevention. And she provides technical guidance on harm reduction and the health of people who use drugs. And she's written a book, Narcomania, Drugs, HIV and Citizenship in Ukraine. And this has received the prize.
An excellent book.
I am. So we must all get a copy. And you've got a slide, haven't you? In your slide deck,
Yeah.
So that's really good. So we must all get that book. Yeah. So she's looking currently at how punitive responses to drug use, including arrests, drug seizures, drug-induced homicide prosecutions, how all that leads to an increase in overdose in local communities. So thank you very much, Jennifer.
Yeah, thank you so much for having me. And before I forget, I don't want to sell New York short. They have 2 overdose prevention sites now, not just 1. But thank you so much. So yeah, I'm going to be talking a little bit about some of the work that I assisted with many of my co-conspirators, some of whom are on the call, in submitting with the collective to this special issue of American Journal of Public Health, and that's focusing on some of our work in Western Russia. And then I'm going to be touching a little bit about the war in Ukraine that Russia is currently waging, and some of the things that we know about the impacts that this has had on key populations, especially people who use drugs or people who are seeking or utilizing opioid agonist therapies. So I thought for a while about how to get a snappy title for my section. I was like, oh, there's so much. There was COVID, and we went to Russia, and there was war, and then went to Ukraine. So I just decided to go with that. So I called it COVID, Russia, War, Ukraine. Hold on, am I paused here? It's telling me my screen sharing is paused. Are you seeing it?
I can't see.
It says it has started screen sharing, but maybe just give it a second.
Let me do this one more time. My joke will land in a second, you guys, I swear.
Don't worry.
Yeah, it's taking me to pause and it won't let me resume.
Do you want someone else to do the screen share? If you send it over, I could.
I've got it here, actually. I could probably, I don't know if I'm allowed to share. Looks like
yeah, you are, Joe. So go ahead, by the way, Joe, if you want to share your screen instead.
Well, James Bunn, can you help Jen to share hers?
Yeah, I've got some permissions issues, sorry.
No worries, no worries. I'm not too sure because we tried it before the call, didn't we? And it loaded up just fine.
I mean, I have shared mine.
We got it.
But I don't, Jen, does that help you? Because you can't scroll through the slides. I can do it for you though.
If that's not too obnoxious, that would be extremely helpful.
There's no problem for me at all.
Thank you. All right, there's my joke. All right, fabulous. Thank you, folks. So I'm going to be talking a bit about some of the things we learned about the impacts of COVID-19 and those restrictions on people who use drugs in St. Petersburg, and then on to happier times with the war in Ukraine. Next slide, please. And you can click 2 more times for me, please. I took out all the animations, I think, except this one. And 1 more time, please. Oh, Okay, there we go. Thank you. So these are the two areas particularly in which we were working. So on the bottom, I've been across Ukraine for quite a while, and I'll be talking a little bit about as much as I know. There's probably people on the call looking at the list who are a bit more updated than I am. They don't call it the fog of war for nothing. But I'm going to start north in St. Petersburg, where we were doing a study that we contributed to the collaborative about how people who use drugs were impacted. Next slide, please. So the purpose of this was to really look at how the COVID-19 epidemic, especially its strictest lockdowns and quarantines, were impacting people who use drugs. There's a lot of very intelligent people making very intelligent hypotheses, like things will get worse, drug markets will destabilize, treatment will be harder to get. There may be more aggressive or forceful policing because of the need to enforce lockdowns or things of that nature. So this study actually emerged as what we call in the US an administrative supplement. It's a financial term, but also a sort of an adjunct to a project that was already running called Stigma, Risk Behaviors, and Healthcare Among HIV-Infected Russian People Who Inject Drugs, or the SCRIPT study. The PI is Dr. Karsten Lunze, who is with us today. He's fantastic. Essentially, the reason why we wanted to do this in St. Petersburg is one, that we already had ongoing relationships with people who are participating in this study. There's a whole team of folks between the US, Germany, Russia, Ukraine, who have actually been collaborating on this project. So it was a really natural collaboration, and there was just a lot of concern for these populations. So we took this opportunity to talk to folks already in the study who we were able to just bring back for more interviews. Can you take me to the next slide, please? So this is the structure of the SCRIPT study on the left, that there were a number of people recruited. The inclusion criteria were being an adult, living in St. Petersburg, living with HIV and not currently receiving any treatment, and living with an opioid use disorder and also not currently in treatment. So what we did was recruit from these folks in the orange on the right, the 67 people who went through this intervention in the larger randomized controlled trial. It was an anti-stigma intervention in which people came in for a few different sessions in groups to work on emotional regulation and setting goals and things of that nature. So between March and June 2021, we conducted semi-structured interviews with folks in St. Petersburg, Russia. It's a little bit misleading. We did not actually get to go to St. Petersburg, Russia. So we did interviews with people in St. Petersburg, Russia. But it did feel like quite a time to be alive when we had me in North Carolina in the United States, my partner, Tatiana, who's in Ukraine, usually calling from Kyiv or Odessa, on the phone, usually on WhatsApp, with someone who our fabulous partners in St. Petersburg had recruited over there. And we had all these sort of three-way WhatsApp calls to do these interviews. And it was challenging, but I would do it again in a heartbeat. And really what we were looking for is understanding, when we interviewed these few people that we pulled, plus a number of service providers, was what the facilitators and barriers of healthcare specifically were for these folks, and how other things in their environment changed. Next slide, please. All right, so because I can't call everyone out by name, these are all of our collaborators on this particular segment of this larger project. We also have larger teams working in Kyiv and St. Petersburg, to whom we're very, very much in debt, but this is right now where these findings have ended up in print. Next slide, please. So some of the things that we found were unexpected. I know, as I said before, there's a lot of very intelligent people who developed a lot of very intelligent hypotheses about how things were just going to get a lot worse for people who use drugs. In a lot of ways, those predictions were correct. But this one was not necessarily. There were predictions that the drug market was going to fluctuate very much in the United States. That absolutely was the case. If you look at our overdose numbers for the last 2 years, they're incredibly upsetting. And it's the first time we had a sort of natural disaster, quote unquote, really causing fluctuations in the drug supply as opposed to other things. But in St. Petersburg, we got reports pretty consistently that there were no fluctuations in the drug market that people noticed that were so big that they would attribute it to COVID. Oftentimes the answers we got were like, things are always kind of like getting better, getting worse anyway, or things are always getting worse. So it's this constant decline that wasn't interrupted by COVID. So while we do know that there are some things, Joe mentioned earlier that I've participated in some research looking at the connection between drug seizure and overdose, we have been able to demonstrate in some American cities that increases of drug seizures by police does lead to a statistically significant increase in overdoses in the surrounding area, but those increases are not so big that other people notice them, right, and recognize the wave. So there very well could have been impacts of COVID supply chains on local drug markets, but if they existed, no one was noticing them. They weren't of that particular magnitude. We also learned that empty streets in the earliest days of COVID made seeking dead drops for drugs more visible and riskier. So I'm not sure what the situation is right now where you all are. In the United States, this was all very, very new to me and an interesting thing to learn about. But the drug market or actual drug buys, small personal use kind of purchases aren't really happening hand to hand anymore in St. Petersburg. Other parts of Russia and parts of Ukraine, we're hearing this become the norm. Instead, what happens is a system that we've been calling the dead drop system. And so this is where the purchaser will go online to a darknet website, make the purchase. There's folks are just like, there's lots of stores, there's review systems, it's pretty easy to navigate. And then there will be a local delivery person who will bring whatever has been purchased, stash it somewhere at a location. Sometimes you can choose, and it's like around the metro station, right? Or near the grocery store. And they'll stash those drugs, tag them, sometimes maybe send a picture of like, it's underneath this flower pot. And then the client will have to go and find the drugs that have been stashed for them. So because the earliest days of lockdown, the streets were pretty clear, and there were more police out to enforce that quarantine, folks who use drugs said that it was just kind of dire to go outside into public places where these stashes happen and retrieve what they had purchased. So for the first few weeks, it was much harder to obtain drugs. But after that, things began to normalize. The quarantine, or at least its enforcement, began to relax. There ended up being more people on the street, fewer law enforcement out, and then things pretty much returned to normal after that. Next slide, please. There were other things. This is what I found particularly interesting, especially as a medical anthropologist, and especially as a medical anthropologist who identifies as a harm reductionist first and foremost before I identify as a researcher or academic. I guess I say that because one of my major motivating or reasons why I have gone into this area of research that I do is because I hold the honest belief that I feel like is grounded in evidence and not that controversial, that the vast majority of harms that people experience as a result of any kind of substance use comes from the criminalization and or very poor and punitive institutional response to those behaviors. And so what we found here in St. Petersburg, instead of things just blanket getting worse for people who use drugs, we actually found that a lot of things got way better during COVID-19. And the reason why is because the sort of top-heavy, very expensive to operate policing and institutional structures that are meant to surveil, to contain, to bar individuals from services were themselves disrupted by the disruptions of COVID, right? So after the COVID-19 restrictions began, people reported less police harassment or none at all after the first weeks of the lockdown ended. I say less because I didn't scroll through every single interview we had before I got on this call to make sure that not a single person mentioned being touched by the police, but I don't remember an instance from any of those interviews. And I, in fact, remember several instances where folks are like, gosh, you know what? They haven't messed with me in months, like while we were doing the interview, just like putting it together themselves. HIV treatment was relaxed, at least the regulations around obtaining medications. This is true in the United States as well. We implemented some much needed and long overdue telehealth regulations that we are now still fighting to keep in place. But HIV treatment, this suddenly became possible to do follow-up appointments over telehealth, so that people didn't have to make these long train commutes into the city to go to the AIDS center. And sometimes there was home delivery of medication, which also saved people these travel times. And it kind of, especially if you're on public transit, it can take some folks 2 hours to get into the city center and then 2 hours to get out, and it's your whole day just to pick up your prescription. On the flip side, however, substance use treatment, which in the Russian Federation is all talk-based, became totally inaccessible because it was all talk-based. There were not telehealth or phone programs that were implemented or enabled during COVID-19. So due to the fact that the center was shut down and people couldn't meet in person, there just simply was no support at all. For some folks, that became a bit challenging because many people who were in those talk-based substance use treatment programs were there for court mandates. And so long as the center is shut down and you can't receive treatment, you cannot finish your court mandate and you remain in that sort of judicial limbo. Next slide, please. But there was, it wasn't all freedom and fun and games during COVID. There were also a lot of other concerns that were exacerbated, particularly people living with HIV and people who use drugs, many of whom are also living with HIV, found that they had very, very poor access to COVID services. And there's a couple of reasons why this was. Some were externally imposed and some were internally imposed. I think one of the best examples that came up in our interviews of an externally imposed barrier to COVID services is the fact that the substance use treatment facility, which slowly started opening up over time, was not authorized to provide COVID-19 tests. And yet you had to have a COVID-19 test showing that you were negative in order to access certain emergency services or inpatient things of that nature. So because they were not authorized to provide these tests, the narcology hospital had to refer people elsewhere, and that referral was put on narcology hospital letterhead. So, imagine just showing up somewhere for basic primary care services, and you have to show a document that's like XYZ Rehab Center for Criminal Addicts is sort of how that reads in the mind of any other healthcare provider that might be reading it. And so folks were like, I guess I'm not getting a test then, right? So that some people paid money to go to private clinics, money which they may or may not have had in the first place, but many people just declined to receive those services. There's also very significant anti-HIV stigma in healthcare, not only in Russia and a lot of places in the world, but also in Russia. And that belief that stigma fueled a belief that we found very interesting among a lot of people we interviewed. They told us they were not eligible to receive COVID-19 vaccines. Occasionally, there were some individuals who said that their provider informed them that the fact that they were immunocompromised or on antiretroviral treatment meant that they could not get the vaccine. When we spoke to providers, they were like, we don't know how they got that idea, but more than one person shared that idea with us. At the same time, many felt that even if they were technically able to get the vaccine while living with HIV or on antiretroviral therapy, they would not be allowed to receive it in any way, that people with HIV are always the lowest to be prioritized on any sort of priority list. And so they just assumed that they would be denied at the point of service and never attempted to go. Next slide, please. Okay, fabulous. So this is a screen grab that I took from the live map of the front line just yesterday. So this is where we are in Ukraine. And so at this point, I'm going to be transitioning over to talk just a little bit about what's been happening since Russia began its war in Ukraine, especially with people living with HIV, but also people who are using opioid agonist treatment. One thing that bears mentioning here is that unlike Russia, in which these medications are banned outright, Ukraine offers access to opioid agonist treatment for opioid use disorder. Specifically, the two medications they provide access to are methadone and buprenorphine. There were about 17,000 people on opioid agonist treatment in Ukraine at the start of the invasion. And that number was actually quite an improvement when I stopped doing full-time data collection by which I guess I mean my full-time dissertation work, when I was living in Ukraine in 2014, that number was closer to 8,000. There has since been a lot of, I think, liberalization. We could do a lot more, but a bit of that prescription regime, more government support. And so that number has more than doubled in the last decade, which has been really wonderful. Could you click one time, please? Right. So the places that I'm familiar with are Kyiv, Lviv, and Ivano-Frankivsk in the west, Cherkasy in the center, Mykolaiv, Kherson, which was just liberated. I've done work in Simferopol and Sevastopol in Crimea, and most recently in Kharkiv. So these are the places where I had personal knowledge of how OAT programs were operating, especially in the last decade, and I'll be offering updates from those places as well as I can. But mostly what I wanted to point out is that some of the places where I've been able to do work have had wildly different logistical relationships with this and previous Russian invasions during this decade. So next slide, please. So a lot of what I'm going to be sharing today comes from work that was hustled out the door by a bunch of really, really great advocates for this type of work. The first one published in Lancet Public Health by Rick Altice, and the second published in Lancet Regional Health Europe by Daniel Bromberg. These are both really, really informative pieces. There's been a bit more since these came out. I know Medscape has covered this. There's been some really nice long form by Al Jazeera and a few other places. But if you're looking for thoughtful, detailed assessments of what exactly is happening with these national systems, I recommend these two pieces implicitly. Next slide, please. Okay, so just as a reminder, there were about 17,000 people on opioid agonist therapy before the war and about 150,000 people on antiretroviral therapy for HIV. That is not including separatist controlled regions in Donetsk and Luhansk Oblast, which is the area occupied prior to the invasion in February, or in Crimea, which is the area illegally annexed in 2014. Next slide, please. So what's happening with medication access? Some positive things, some not so positive things. So there have been expansions, as I mentioned, some liberalizations of the prescription regime for, sorry, that should say OAT, not MOUD. I got a little too American on you this morning while I was editing these. So opioid agonist treatment is now legally obtainable through private clinics through a fee-for-service model. This is not obviously the solution for everyone, but it is good to have choices and more options, especially given that in order to receive OAT treatment in public clinics, you have to go onto a registry of known narkomani in your city that is maintained by the police. It operates very similar to the sex offender registry that we keep in the United States. Like, you can't live near a school, you can't have a driver's license. So even though it's through a fee-for-service model, having this available through private clinics, great, no complaints. It allows just people different options. And this was liberalized even further recently because there was a way in order to get around legislation to go to the private clinics to pay for these medications over the long term, because these are, of course, long-term treatments. They're not meant for short-term tapers. And they used to be able to file the prescriptions as long-term detox. So like, we're tapering this person just over a year and a half, right? And so now they're able to just above board offer that treatment. The Ministry of Health has allowed 90 days of a take-home supply for antiretroviral treatment for people living with HIV. That's an increase from what they were allowing in the past. There was also an increase to a 30-day take-home supply of opioid agonist treatment medications. That is the type of take-home prescription regimen that in the United States, we require people to be basically perfect and have urine that smells like baby's breath for almost 2 years before they're able to get access to. Interestingly, this was partly the result of policies that were implemented during COVID-19. I know especially in Kyiv City, in the capital, there was a shift to allowing 30-day take-homes when COVID happened and the strictest restrictions and quarantines were in place. And many people, they switched, if I'm not mistaken, 100% of people over to the take-home regime. After that mandate to do take-home ended, a few people, I've been told by local collaborators, around 10% went back to supervised supervised dosing largely on a consensual and request-based basis. But the vast majority of people continued taking these take-home. So they liberalized for the purpose of COVID and then just never undid it. And then at the beginning of the war, this became a nationwide policy. Some clinics were collaborating to ensure that those medications continue to be available despite disruptions. And so that involved like clinics stockpiling medications together, working to coordinate with patients together, especially as different supply chains were disrupted. And then really, really wonderfully, there were a lot of, well, I guess I shouldn't say wonderfully because it's sort of devastating that this was needed in the first place, but people can be really amazing. And there were a lot of mutual aid groups, social networks, just open lines of communication, especially on the Telegram app, where people were updating each other regularly, sort of like a live Reddit thread about where medications could be found, what pharmacies were stocked that morning. And so there was this sort of crowdsourced information about what was happening with supply chains that patients could make use of. And the picture on the right, I actually grabbed this sometime back in March, but these, because it's still winter, this was taken, but this is an organization that works in Dnipro, and Dnipro has remained under Ukrainian control and has not been occupied by Russian forces, but it has been very close to a lot of the front lines, has been hit by a lot of shelling. And these are individuals from a harm reduction group in Dnipro who continued going house to house, delivering medications, delivering naloxone, providing sterile syringes, even as the earliest bombardments were happening. Next slide, please. All right, so things that are hindering medication access. I'm sorry if you were hoping to not see Putin this morning, I apologize. One of the reasons why I put him here is because, I don't know if folks recall, this happened, I believe, back in March or early April as well. When you say, the bizarre speech that Putin gave, that's become profoundly less specific these days. But this was one of his earliest addresses after the war began. I believe his second or third public address after the war began, where he was still pushing the anti-Nazi, the false anti-Nazi tone of the invasion. Because that still apparently had some traction with some people. And he referred to the government in Kyiv, specifically to Zelensky's whole administration, as gangs of neo-Nazis and drug addicts. And it was very, very, I don't know, it was surreal for me to hear, because I wrote an entire book about how the marginalization of people who use drugs became a key process in establishing sovereignty in occupied Crimea, and the way in which these sort of like exclusionary processes are actually very central to the imagination or perception of the Ukrainian state, as well as different calls for, I guess, Russian-backed calls for independence in Eastern Ukraine. So hearing this discourse again and again and again still being used, like appealing to the presence or accusation of drug use as a discrediting and exclusionary tactic. Like my book is still right, and that makes me sad. But the things that, in addition to the discourse that really relies on the exclusion of people who use drugs as a sort of anti-citizen to prop up the idea of the state, which is pervasive and very impactful. There were also a number of logistical things that were happening that were hindering medication access. I know, he's been calling people Nazis forever, and that's wrong. But I thought of this, I'm responding to the chat. Karsten is making a apt observation that this has been an ongoing thing, so it was not limited to this one speech. The specific phrase gangs of Nazis and drug addicts was specific to this speech, and that's what I was hoping to call attention to. But there is no state level disaster plan for patients that are receiving opioid agonist treatment. Treatment plans for people who are impacted by the war are largely left up to local physicians during emergencies, who may or may not have the appropriate level of training to make those decisions. Some private providers, despite the liberalization of that prescription regime, have been discouraged from providing OAT, serving as a certainly insufficient but helpful and important to maintain stopgap to other public services. So they've been discouraged from providing OAT by state action against unscrupulous providers. So essentially a few targeted campaigns in which folks have been accused of being what in the US we call pill mills, or unscrupulously prescribing opioids to people. At least at the beginning of the war, and I'm not sure what the situation is with inventory now, but the vast majority of the stocks of these medications were kept near Kiev. It's a centralized healthcare system, and they're sort of go out to the oblast, and the oblast give out to the clinics, and so on and so forth. So the entire nation's stockpile of these medications, after a few weeks when local supplies were running out, were kept in the city that at the time was being bombarded, was being barricaded. This is when some of the heaviest fighting was still in the Bucha and Irpin area, and folks just couldn't get the medications out. I even heard really active and intelligent researchers and advocates calling for like the purchase of drones, to be like, we will just fly the damn medications out of the city if we have to. We've got to find a way to do it. There were a number of pharmaceutical factories that were making these medications in country, another great development, because when I was doing this work full time in 2013 and 2014, the vast majority of these medications were imported from Germany or from India. That certainly slows things down. And then finally, there's been lots of public communication about antiretroviral treatment for people living with HIV, for people who are diabetic or need tuberculosis care, but there's been no public comment, at least that I am aware of to date, about opioid agonist treatment and accessing it. There has been, back in May, I'm aware of at least one sort of like situational report about access to opioid agonist therapy. I can throw it in the chat. I apologize, it is Ukrainian, but Google Translate does a pretty good job. So this was put out in May with a bit of information about the status of folks receiving this treatment, but in their public channels, in their Telegram channels, in their SMS pushes, that's not really being messaged at all. Next slide, please.
Right. Oh, sorry.
Thank you. I appreciate it. So what you've got on this slide, for example, on the right is an example of the type of public messaging that this is actually the Center for Public Health, part of the Ministry of Health of Ukraine, is putting out on their Telegram channel. Like, for example, it says, important people living with HIV can receive antiretroviral treatment in their in the town where they're actually located. And this is one of the, again, sort of like liberalized prescription regimes that they're putting into place because of disruptions of the war. They've been able to do things like reduce accounting requirements for reimbursement and payment of different clinics. Recently, Ukraine nationalized its primary healthcare system, and there are a lot of government payments that are tied to individual patients, to individual dispensing of medications, things of that nature. And essentially, the government said that they're just going to send every clinic 12% of the cost of their annual contracts with patients without requiring any sort of receipt or reimbursement forms. That may have changed at this point, but that was happening at the beginning. They created a hotline to assist patients with medication access. Of course, the hotline has to know where those medications are as well, so it suffers similar limitations as civil society. There's a lot of coordination with neighboring nations like Poland, Moldova, Latvia for the continuation of care. And importantly, they've listed the address and registration requirement for HIV, tuberculosis, and opioid agonist treatment. So what that means is that the same way, I'm sure you guys have some sort of similar regulation in the UK. In the US, for example, our public schools, like which middle school or high school you go to depends on where your address is. There's a similar sort of system in Ukraine. It's a legacy organizational characteristic of the Semashko system in the Soviet Union, but you are essentially registered at a particular address. That's where the state knows you to live. And based on that address, you have to vote in specific polling places. You have to go to specific schools, and there's specific hospitals and polyclinics that you're supposed to access. And so if you are far away, let's say you're away at college or you're a displaced person even, and you're still registered back at home, you're not supposed to be able to receive treatment in the location where you are, and you're supposed to go back home to do it. And that restriction, fortunately, was lifted. Next slide, please. Okay, so part of the reason why I think these things are important to keep in mind, like I said, there are some positive developments around drug policy and treatment policy after COVID-19 that were maintained, but mostly war sucks and is hardest for the people who are the most dependent on particular supports, especially because they've been socially, structurally, and medically marginalized for so long. I was recently giving a talk on the status in Ukraine at the American Anthropological Association. And one person asked me, it was the question that I love and hate to get at the same time, which was, if you could tell Americans one thing about Ukraine, what would it be? What's the one thing that you wish you could help people understand? And I said, well, other than the fact that when you read a headline that says the US government has given $3 billion in military aid, we're not shipping over duffel bags of cash. It's like old tanks that we were warehousing and probably losing money on warehousing. But in addition to that, it would be that folks who have connections to this region and are familiar with this region have this, I think, terrible sense of foreboding that is not shared by a lot of people who are not familiar with it. And so when I know folks here who have anxieties about this war, they're worried about World War III or Putin going nuclear. And yes, that would be terrible, and we don't want that. But at the same time, at least from where I stood, I saw a lot of people reeling, appropriately so, at the bombing of the maternity hospital in Mariupol, or the findings of terrible human atrocities at Bucha and Irpin. And having watched the annexation of Crimea, having watched the Russian fomented and supported separatist conflict in eastern Ukraine, and territory move in and out of there, having watched what previous Kremlin influenced governments in Ukraine have done, I think it's no surprise to everyone that those types of human atrocities are already happening and have been happening in occupied areas for a very, very long time. When I was in Kiev in 2013, 2014, during the Euromaidan revolution of dignity, I just remember people disappeared all the time. And I remember folks constantly discussing how terrible the spring was going to be because the snow was going to melt and we were going to find all the bodies that had been stashed in the woods. So every time a new area is cleared, when they liberated areas east of Kherson, when they liberated Izum, when they Kupiansk, when they liberated Kherson, they're finding mass graves everywhere. And so I guess the one thing that I would wish all Americans would know about this war is that we all know that there's massive tortured and dead civilians in these areas, because that's how the Russian army works. But in addition to all of those things, I think the reason why it's very important to dedicate some time and energy to following the situation, supporting where you can, but that's very hard as an individual person very far away, but being concerned with the condition of people who use drugs in these war zones is because they are sort of doubly at risk because of some of those discourses I mentioned earlier. The actual piece that I have put up here is from 2017. So it's obviously before this current war. But when Russia annexed Crimea in 2014 illegally, there were at that time 800 people on the peninsula who were receiving opioid agonist treatment for opioid use disorder. And I mentioned previously that I had done some ethnographic work there, and I can tell you firsthand that these were phenomenal clinics led by phenomenal doctors with patients who were thriving. I didn't want to leave. I was like, I want to live here in this Crimean clinic forever. It's the happiest place I've ever been. And after the annexation, because those medications are illegal in Russia, it was announced by the Federal Drug Service in Russia that these clinics were going to be closed down. But because fluctuation in the drug market leads to overdose, fluctuation in tolerance leads to overdose, it's well known that ending these medications abruptly is a massive, massive risk factor for overdose, increases your risk of overdose by orders of magnitude. And despite the fact that Russian authorities initially said that they were going to extend these clinics' operation until maybe the end of the year, these announcements were made in March or April. They shut down all the clinics with only a few days' notice in May, sent everybody reeling, actually have, and I mentioned this in the book, they actually had an AP photographer on hand for when several security guards were popping the last of the methadone into an incinerator, because the disenfranchisement of these people, I argue, was a very key act of statecraft in this area, essentially, like disenfranchising people to prove that they can and thereby show that they're in control of the region. So more than 100 of those 800 people died. So 1 in 8 people died, often of overdose, sometimes of suicide. And those are people whose biggest challenge was the loss of treatment. There was no actual active hostility, no fighting, no bombing, no land mining inside of Crimea. So folks in those occupied areas are having a much, much worse time. I believe that's, next slide. Yeah, that's okay. So I wanted to leave folks with 2 resources. Yes, this is self-serving, but also it's not. So I wrote up my argument about how banning methadone in Crimea is an act of statecraft in this piece, excuse me, that came out in 2018 in Medical Anthropology. It's open source at PubMed Central. That's the scientific repository kept by the US government. And I do have a whole book about it. And thanks to a generous grant that I did not apply for or receive, Cornell Press applies, so they get all the credit, but from the National Endowment for the Humanities, the version of the book, either an EPUB or a PDF, is completely free to download on the publisher's website. So please avail yourself of that. There's a whole chapter about Darth Vader, if that attracts you to the book at all. But yeah, I don't make any money on that. It's just free. But yeah, thank you very much for your time.
Great. Wow. Just absolutely brilliant, Jen. So much that I guess most people have absolutely no perception of what goes on. I had no idea that opioid agonist treatment was banned in Russia.
Yes.
How long has that been the case?
I don't think it's ever not been the case. Yeah, to the best of my knowledge, and again, I'm not a Russianist. Ukraine is my field site. I've actually, this is one of the like second disappointments of not being able to do the study, is that I've never been to Russia. I'm a Ukrainianist who has been working in Ukraine, and I know Ukraine. So I don't keep up with Russian health policy as well as I do Ukrainian health policy. So the long way of saying things might have changed, but to the best of my knowledge, methadone has never been allowable in the country for any medical reason whatsoever, despite the fact that it's, you know, I'm not that kind of doctor, but I'm aware that it has a lot of uses for neuropathic pain. I know it's been used even as like cough suppressants in certain seriously ill patients. So it certainly has plenty of good uses outside of this particular one, but it's banned outright. And what I find particularly interesting, and I wish just as a human who is curious about other humans in the world, not as someone who is you know, rightly focused on human rights and military aggression. But just as a curious person, I would love to spend more time exploring how people in St. Petersburg or other parts in Western Russia are managing their physical dependence on the substances that they prefer, alongside or without an accompanying substance use disorder, because the substance that is most frequently used among people who use opioids in St. Petersburg is methadone. They call it ulichny methadone, so like street methadone, and it comes in a sort of like crystalline powder, to the best of my memory. But yeah, so people are actually using the primary medication for the treatment of opioid disorder. Karsten, thank you. He says buprenorphine was briefly available post-Soviet and in Russia in the early 1990s. Yeah. So we weren't even using buprenorphine to treat OUD in the US at that time. Were they like magically ahead of us, Karsten? Or was it for other purposes? In the US, where like bup only has this one particular use. You know, I'm sure he's typing. I'm sorry. Go ahead, Joe.
Yeah. I don't know when it was available here either. Probably, I think it would have been available here by then. Yeah, I'm fairly sure. But what about other pharmacological treatments? or other drugs? Is that available in Russia?
You mean like safe supply or like
Yeah.
medications for stimulant use disorder?
Yes, all of those, Valium.
To my knowledge, nothing is provided as such. It's in larger cities, at least within the last decade, I have seen it in some places be the case where like you just have to know the right people that can point the right pharmacy out to you on the map, where you can go and get like a single tablet of some, essentially do like de facto safe supply daily dosing at your local pharmacy, but sort of like under the radar, in sort of like quote unquote unscrupulous pharmacies. So some arrangement like that might be possible, but I'm not aware that any medication is acknowledged as a treatment for stimulant use disorder in Ukraine. But again, a lot has been changing, so that might change soon. And I know that there has been a lot of health reform that's been like on the edge. And I think if they stop being invaded all the damn time, they might actually be able to put some of those into place in the coming years. The goal was to reform the entire public health system. They got halted for political reasons at primary care. Secondary and tertiary never got that treatment. But I know they're on paper and they're ready to go. So hopefully there'll be an opportunity to push that through sometime in the future.
And in the war, what happened to pharmacies in the Ukraine?
So pharmacies, I mean, I think the thing that is most inspiring about the response of Ukrainians to the invasion is that like there may not have been any petrol, but they showed up to work at the petrol station anyway, right? Like folks, coffee shops were open, people just kept working. Partially it was, I think, indignance, and I even had a very good friend who fled Kyiv to take shelter at her parents' home, and she was like in her parents' basement in a rural area during air raids, processing payroll for her company. She's like, I just need something to do. Like I need to feel effective in the world. But so pharmacies, a lot of them stayed open. There was a website called tabletki.ua that the Ministry of Health put up before the war, where people could sort of see the nationwide inventory and be like, what are the prices? Sort of like an app that lets you see all the gas stations with the different like prices for petrol, where people could find medication. Obviously, if there's supply issues, like I couldn't find, I found one pharmacy in Dnipro that was selling buprenorphine for like the cost of like a new car kind of. So I was like, this is an error somewhere. And it was the only place so sometimes it's helpful, sometimes it's not. But I will say just this morning or yesterday, the Ministry of Health was putting out announcements that a number of pharmacies in the Kherson region, which was just recently liberated, are operating again. And they've been sharing addresses and phone numbers of all of those places. So I guess the short answer is it's been really hard, and it seems like people are doing their best to get things as available as possible.
Yeah, absolutely, of course. So can you tell us a bit more about the Crimea clinic? What was so great about it? Because it sounds inspirational.
I mean, patients were just happy. I think anyone, especially around something as significant as treatment for a substance use disorder, treatment for independency, like that can be a very challenging place to be in as a patient, because just whatever trust you have or however reasonable they are, like that your healthcare provider controls your access to something that you really need. And if something goes wrong, they become untrustworthy. I don't know, we've all had a friend, a boyfriend, something that just like, oh, I didn't expect you to act that way. And we map that onto our healthcare providers. So it's really frightening to be in a place where you're really, really dependent on another person for something that, like, if you don't get it, you're going to go into withdrawal, you're going to have to scramble. You're not going to know what you're going to do. You're going to be at risk. And so because of that, the personality and just the relationship that patients have with their provider is such an important component of that therapeutic environment. I mean, it's the same here. Like, you can find methadone clinics in the US that are run on paper and logistically are run identically, but you have two different personalities of doctors in there, and patients have two completely divergent experiences in the treatment environment. So I had spent a lot of time in methadone clinics where patients were just like harassed, just were not happy to be there, felt exhausted. Even some whom I interviewed who like, we ended up like throwing out the interview and just kind of chatting with them because it became apparent that like their physician had told them that they had to talk to us in order to get their medications for the day. But especially the one that I was at in Simferopol, like everyone was so happy. And like, I would be in meeting with the head doctor, and like, while I was with actually a representative from a national NGO. So like a dude in a suit, a white foreigner, and the doctor are like having a meeting, and patients would still come in and be like, excuse me, sorry, and like steal candy off the table and be like, thank you, goodbye, and run away, So just like levels of interest, physicians like pointing out pictures on the wall of like all of their patients and all of the patients' children, and folks bringing their children into the clinics, and the nurse throwing the kids up. I mean, just really, really great clinics where folks just felt super taken care of, were really excited about where they were in their lives, had just like so much hope, and clearly had received so much social and psychological support because they had really robust narratives for themselves, right? And building narrative is part of the like post-traumatic therapeutic process. And so it was just really, really heartbreaking to know that not just were people who are particularly vulnerable put particularly at risk by these completely unnecessary and theatrical actions on the part of the Russian government, but that it was the loss of a clinic that honestly I think was a model for a lot of other places. It was like, they shouldn't, like, none of these clinics should have been shut. It should have been none of them. But the fact that it was also that one was rough. Yeah,
heartbreaking. And that's, an example to us all, isn't it? Everywhere clinics should be like that.
Mm-hmm.
Safe
Yeah.
spaces. And as you say, all the social and psychological support.
Mm-hmm.
So important. Brilliant. So Caroline, I have a question for you from Aurora. I think you've seen it. It might be fun if you answer it for us. It's a multi-dimensional question.
Yeah, no, thanks, Aurora. I guess it was just about thinking about things that have happened during COVID and changes, and what do we expect to see in the long term. And I actually, in thinking about that question, some of the stuff that I think didn't make it into this paper, but I'm now much more aware of from spending more time in UK-based prisons, is thinking about what's happening in prison systems. And so on the one hand, there are some governments managing to achieve kinds of decarceration, generally never as impressive as they've kind of announced, but also some quite worrying trends. And I'll give you an example. A lot of UK, well, especially England and Wales, prisons during lockdown did a few changes. One was a measure where you make sure that prisoners are in smaller groups to reduce contagion. And so like this group of 20 people will never interact with this group of 20 people, which requires a bit more supervision of correctional staff to shepherd this group of people to the bathroom, to the canteen, etc. And at the same time, there was a lot of staff attrition. So this is not just in prisons, it's across sectors, right? People leaving their jobs, not staying, doing different stuff. So as kind of this thing of segregating people took hold, a few things were observed. One was that basically they were like, oh, now people are in smaller groups, people are easier to manage. And also, if we just keep people in their cells for longer, we have kind of less drama. So with staff going down, there's this really worrying thing now that people are stuck in their cells for a lot longer, getting way less educational like stuff going on in the day, way less time to walk around, to be outside. So in a way, like a lot of the measures that were introduced to reduce contagion that involve loads of social isolation have turned out to be kind of cheap because you can have fewer staff. And so that's very concerning. And a lot of, for example, the prison-based teaching that Manchester University used to do is now kind of on hold. We can't get back in because there aren't enough staff members. Yeah, there aren't enough staff members to safely bring people from one wing into another. So that's, and then that's not just in Manchester, that's kind of all over the place. So prisons are understaffed and sticking to COVID era levels of cell time. So that's concerning.
Yeah.
And yeah, like I don't know the extent to which that is also mirrored in US prisons, Jen. When I was in New York State earlier this summer, that definitely seemed to be the case in the universities that Columbia and Bard were teaching at. So yeah, that stuff's concerning. I don't know if you want to, yeah, if there's another thing to chop onto that. My brain fog is struggling.
Well, I mean, in the United States, we had, I mean, like, I think there's you can get more detailed, but the higher facts are that like our numbers went down, but very modestly, and that many of the same restrictions are still in place. So a lot of the knowledge that I have is from my work with the North Carolina Women's Prison Book Project, where we correspond with people who are incarcerated in facilities labeled women's facilities. There's a gendered prison division of labor that predates my time in Durham, North Carolina, so you'll have to ask someone else about that. But another group writes to the men's prisons. But yeah, like their libraries have still been closed, their personal belongings are still restricted, and there have been some things opened back up, but for the most part, changes that occurred during COVID-19, which have not been great, have sort of remained. I've even heard anecdotes of recreational facilities being converted into like isolated, socially distanced work facilities for prison labor, and them not reverting back after. So
Yeah. And I guess another thing that we know in the UK is that in terms of the new forms of policing that emerged specifically to police adherence to COVID rules, that there was huge ethno-racial disproportionality in who bore the brunt of being arrested or being fined, and that fell disproportionately on Black and Asian communities in the UK. And yeah, I don't know the extent. I don't know the extent to which those are still live because we've lifted restrictions now, but I think there's still quite a lot of active appeals against fines that were issued in 2020 and early 2021, and that was not equally distributed across the population by any means.
So Jennifer, could you explain to us, you talked about an increase in seizures leading to increased drug-related deaths. Can you explain to us that link?
Oh, yes, absolutely. So this is unpublished data. It's currently in review, and it was presented at the US National Harm Reduction Conference in Puerto Rico in October. But there's a study I'm working on, and I should mention, I'm not the statistician on this one. It was other intelligent minds. I assisted with conception and write-up. But we were able to get data, at this point, we will call it a large Midwest city in the United States. And we were able to get data from their police department on drug seizures. And that's not just like a big bust like on TV, but like literally taking a dime bag out of someone's pocket. So anytime they take any illicit substance into their possession. And so we had that information, we had the date, time, and the location at which it happened. And we had at least the presumptive description of what it was. Sometimes it's literally like an officer kind of holding it up and being like, heroin, you know, but obviously they get tested in the lab, but like that's what gets written down in the property room. So what we were able to find is that within the 100 meters around the location of the seizure for the subsequent 7 days, there were significant increases in non-fatal overdose and naloxone administrations after an opioid seizure, but increases in fatal other way around. There was an increase in fatal overdose in those 7 days, increases in non-fatal overdose events. So events that were thankfully reversed and the person survived, remained significantly increased outward to, I believe it was 500 meters in 21 days. So there was a significant long-term effect on the increase of overdoses in that area. That was for opioid seizures. For stimulant seizures, there was still an increase in non-fatal overdoses over 7 days within 100 meters. And so these were not changes in the overdose rate that were significant enough in a town of close to 1 million people, where folks were really feeling it, where they would feel that wave happen. But when you look at the EMS data and the death data, the pattern is absolutely there. If it's not clear why this happens, I would say very, very briefly that when it comes to understanding how yes, you overdose because you take too many drugs, but it's not helpful in this regard to think about overdose as just like a natural consequence of drug use, which is naturally risky. It's much more accurate and helpful to think about it as the loss of ability to match tolerance and dose. And you can think about things that put people at risk for overdose of like, well, if you need your tolerance and dose to match so that you're not having a really bad day, which you try to avoid, or possibly dying, then what messes with tolerance? And so this is why a weekend in jail will increase your overdose risk, why incarceration will increase your overdose risk, why abstinence-only treatment or rapidly ending, like opioid agonist treatment, because your tolerance has fluctuated and you don't know quite where it is. On the other hand, if your dose fluctuates, that will also put you at risk of overdose because it's hard to match. And this is part of the reason why we had such a surge in overdoses in the United States after our Food and Drug Administration reformulated OxyContin, a prescription drug that was being heavily diverted and sort of moved illicit opioids into new markets that they hadn't reached before. Absolutely, OxyContin was a public health problem that required a response and was costing lives that it shouldn't have been costing. But OxyContin came with an ingredients list and a dosage that was very clearly labeled. And so the risk environment was actually significantly exacerbated by taking something that at least had a known dosage essentially out of circulation. And everyone filled the gap with illicit drugs of illicit manufacture. And so we have found really compelling mixed methods evidence. So not quite yet large environmental sort of studies of this, but multiple qualitative pieces in multiple areas that have kind of demonstrated this as a mechanism, that when you arrest a supplier, you're putting that supplier's clients at immediate risk of overdose within the next 48 hours. And this is actually an insight that we received not only from people who had survived overdose. It was a study where we met folks in the emergency department and we're kind of like, what's different about today? If you're someone who uses drugs every day, why are you here today? What was different? And they 100% of the time, they said, I couldn't find my primary trusted person. But also we heard this from first responders who were telling us that every time there was a big police raid, they would have to put extra naloxone in all of their ambulances because folks would be falling out. And so essentially what it is you have to go to another supplier, someone who you may know well, but you just don't communicate as much with or don't have as much experience with, and people attempting to be very cautious with one another even still might miscommunicate. And at the risk of sounding glib, because I think it's a very serious issue, I sometimes think it's not that different from the crisis is a strong word, but like the problem that one has if you go to like a new Thai restaurant and they're like, how many stars do you want your spicy pad see ew? And you're like, I don't know, what is 4 stars here? Am I going to regret being alive? Like, is this going to be really mild, and so that's I think one example of how people even trying very earnestly to communicate with each other about strength and potency can still have miscommunications and accidents can happen.
Absolutely. So I was just wondering about the type of drugs that appeared on the streets in the pandemic and in the war. Was there a change in, were there more synthetic? We had the horrendous spice epidemic, didn't we?
Oh, spice. Please don't do spice. It terrifies me. I have like 2 irrational fears, and one is new variant Creutzfeldt-Jacobs disease, and the other one is synthetic cannabinoids. They terrify me. I think importantly, one of the things that we found in St. Petersburg is that folks were not really noticing a fluctuation in the market that they attributed to the pandemic. And so, like I said, it could be very similar, right? That there were pandemic related fluctuations, but that there was always such fluctuation that it became hard to kind of pull that thread. Folks consistently told us like, oh, it gets better, it gets worse, it gets better, it gets worse. That's all the time. We also had folks just be like, it's always getting worse and it's still getting worse and it hasn't stopped getting worse and all the drugs are crap and that's where we are, COVID or no COVID. And in the United States, however, we actually saw, like I said, massive fluctuations in the drug supply, and a lot, certainly more people were using alone during the pandemic, which is a risk for an overdose turning fatal because you cannot reverse your own overdose. But most often, I think we can fairly attribute a lot of the massive increase in overdose we saw during the first year of the pandemic to fluctuations in the drug market. We're starting to see more cross-contamination of across stimulant and opioid products. We're starting to see xylazine, a different kind of additive. It is an opioid-like substance that is not necessarily an opioid. It has some sort of receptor activation, and the sort of like man on the street take on it is that while fentanyl is really fast acting, is very strong, gives a pretty strong rush, and it's been hypothesized that biofeedback at the beginning of dosing is part of the reason why it kind of became popular to begin with. So like heroin with a little bit of fentanyl, that xylazine sort of has the opposite effects that it has the legs that fentanyl tends to lack. So now that there's so little heroin in the United States, we have fentanyl products that are strong and come on fast, but also fade fast, and then xylazine being added to it to sort of stretch it out. And that is resulting in different manifestations of overdose. It is because it has partial receptor activation, and we're going to get above my pay grade real quickly. Naloxone is not always able to knock it off the receptor. I think it's very inaccurate to call it naloxone resistant. I see that word used a lot, and I would warn against it very strongly. It's just not, naloxone is not an antagonist for that particular drug. So those are some of the things that we're seeing, and it's changing patterns of overdose. And I honestly, I can't tell you why. There seemed to be some stability in online markets in Eastern Europe, and there seemed to be so much fluctuation as was predicted in the United States. It may be a difference in measurement of like how we're assessing that change. It may just actually be differences in the regional drug market. It's hard to know.
Yeah. Just to add on to that, I think another thing, thinking about markets that we saw internationally. So in lots of countries reported that everybody started drinking more during lockdown. That was a big thing. But some countries, I'm thinking here about Iran, South Africa, India, and Sri Lanka, took measures to either ban or reduce alcohol sales to kind of counteract that. And in our research, we, from our field reports, found that was producing quite a lot of poisoning deaths from unregulated homemade alcohol with methanol content. So that was another area in which, there was a kind of prohibition move to counteract something that, backfired in different ways. I don't know how long that persisted for, but it was another surprising outcome.
Shows you the effects of prohibition.
Yeah.
Horrendous. Wow, just what absolutely brilliant, you two. Thank you so much. This has been so enlightening. I think I know you've got some of your colleagues here. What's that?
Said thank you.
Okay.
Thank you.
Thank you, Darren. Fascinating, thought-provoking, and hugely informative.
Thanks,
and covering
Darren.
topics that, I think most of us, certainly me, didn't have that much knowledge of, and it's absolutely enlightening. And we should all definitely buy your book, Jen, and read your paper.
Just download it for
free book. Yeah,
don't buy it. Just take
it's free.
That's absolutely brilliant. Thank you so much. I don't want to keep you any longer because, Jen, I know you have to get on with your Friday. It's probably touching 11 o'clock with you.
I have to go back to bed.
Oh, sorry.
Yeah, we don't want to strain you any further. I can't see any questions. Yeah, super fascinating, totally super brilliant. I've loved it. I've learned so much. I really have.
Thank you so much.
Yeah, so this will be available, everybody. So, you'll be able to access it and bring all your friends around and send it to them and all your colleagues. I think it's really important for lots of people who work in this field to hear all about this. Absolutely fascinating, brilliant. So much work.
Opportunity. Yeah, I'm always very, very pleased to be able to talk about this, and the world is not just constantly throwing opportunities at you to brag about the incredible harm reduction community in Ukraine, but it is thick on the ground, and they are extremely good at what they do. I'm exceedingly grateful for them. Yeah.
It's so interesting, isn't it? To hear about the Crimea clinic, to hear about, what people are doing in Ukraine. It's just brilliant. And what happened in the pandemic. Absolutely extraordinary.